Bismillahirrahmanirrahim. Our lecture today is regarding the parathyroid glands and the main syndromes. This is the normal histology of the parathyroid gland. They are 4 glands, 2 pairs, 2 upper and 2 lower parathyroid glands behind the thyroid. And this is the normal histology in which there is the endocrine part may be made by the chief cells and occasionally the oxyphil cells, and it is normally infiltrated, or there are islets of adipose tissue, mature adipose tissue within the normal histology. So to differentiate it from parathyroid adenoma. Okay. Normally there should be an islets or lobules of mature adipose tissue within the normal parathyroid gland histology. These are the chief cells. Oxyphil cells are of eosinophilic cytoplasm, and these are the islets or lobules of mature adipose tissue. The secretion of these chief cell is the endocrine secretion is the parathyroid hormone, PTH. And the main stimulus for PTH is lowered serum calcium. And this is the normal serum calcium, which is from 9 to 10.5 milligrams. So lowering serum calcium is the main stimulus for the secretion of PTH, parathyroid hormone, from the 4 parathyroid glands. And this parathyroid hormone secretion is antagonized by calcitonin secreted from the parafollicular C cells and the thyroid follicles. Usually there are 2 glands, in 2 pairs, from 4 from the pharyngeal pouch, upper 2, and the inferior 2 are from the 3rd pharyngeal pouch. The physiology of the action of PTH, the physiology of action of parathyroid hormone, which is secreted mainly by the chief cells. It acts to increase the free ionized calcium in the blood, okay, rather than trophic hormone. يعني secretion of this PTH it is controlled by the low level of free serum calcium or calcium in the blood, and causing macrotrophic hormone for it, macrosecretion from the pituitary. It is controlled by serum calcium level, and its action is antagonized by calcitonin. The action of 3 main physiological action for PTH to increase serum calcium normally, and you should know them. Increase serum calcium. As you know, serum calcium in the blood is found in the bounded to protein in 60% of its amount. Another amount is complexed with phosphate, and the remnant or the remaining amount is called the free ionized calcium. That is the active form. So the action of PTH is to increase the serum calcium and phosphate level. How these mechanisms are made is by increase the reabsorption of calcium from the gastrointestinal tract, from the small intestine, by increase the renal reabsorption of calcium, and increase renal excretion of phosphate. بنزيد الرينال excretion إن إحنا the amount of phosphate is bounded to calcium in the blood. بنزيد renal excretion of this phosphate, free calcium should be راح يصعد. تمام? This will increase the level of free ionized calcium. Also, this PTH act on increase the osteoclastic activity. Osteoclastic activity means the osteoclastic activity اللي هي bone resorbing cells يزيد السيرم كالسيوم يطلع. This will generate calcium and phosphate. The effect of PTH on bone or on increasing calcium by bone resorption is indirectly, so it is directly increase the activity of bone forming cells اللي هي osteoblast. صحيح؟ Bone forming cells are the osteoblast, and these osteoblasts will be stimulate also the action of osteoclast bone resorbing cells. And also the conversion of the vitamin D to its active form, that is active form, alpha-1 dihydroxy form in the kidney to increase the excretion of phosphate and increase calcium reabsorption from the GIT and from the renal tubules. Okay, for the normal physiological action of PTH, it acts on what? Or act on the? Yes, act to all the mechanisms are collectively to increase the normal, to increase the free ionized calcium by increasing serum calcium and phosphate level, by increasing gastrointestinal reabsorption, gastrointestinal absorption from the small intestine, by increasing the calcium reabsorption from the tubules, and increase phosphate excretion. This will lower the bounded form with calcium, and the also act on conversion of the vitamin D to its active form in the kidney. So increase the excretion of phosphate by the kidney will lower the serum phosphate, and this will increase the level of free ionized calcium. All these mechanisms will result in net of increased level of free ionized calcium. And this will, when there will be a correction of the free ionized calcium or normal level, this will inhibit, this is the inhibitory negative feedback mechanism to stop the secretion of PTH by the chief cells. The most common cause of clinically apparent hypercalcemia is malignancy. Malignancy, when there is cell destruction, bone resorption, this is the most common cause of clinically apparent hypercalcemia, whereas asymptomatic hypercalcemia is mainly the present caused by primary hyperparathyroidism. And the primary hyperparathyroidism can be symptomatic or asymptomatic. It is mainly asymptomatic. Okay, شباب types of hyperparathyroidism. تمام، اكو hyperparathyroidism واكو hypoparathyroidism. Hyperparathyroidism, it can be primary, secondary, and tertiary. Primary, secondary, or tertiary. Secondary, tertiary are related to renal failure, chronic renal failure. Then, whereas the primary, it is the most common cause of asymptomatic hypercalcemia. زين، يعني واحد يسوي، يعني يشوف من ده يسوي مثلا checking، يشوف incidental hypercalcemia. And the primary is most commonly caused, more than 80% of the cases is caused by parathyroid adenoma. زين، خلينا نشوف parathyroid. هذه شكل الباراثايرويد جلاند. parathyroid adenoma is retrothyroidal، يعني اللوكيشن مالتها تصير two in the upper pool of the thyroid and two in the lower pool of thyroid. Then مثل ما قلنا 3 times. The primary should be the most common cause, parathyroid adenoma in more than 80% of the cases, and secondary and tertiary are related to chronic renal failure. There is, in the primary type, there is asymptomatic increase in serum calcium and decrease in serum phosphate. It is related to excess production of PTH by the parathyroid glands. إذا هي parathyroid adenoma حتكون all the glands are secreting no single one. adenoma تكون localized مو صحيح؟ تكون localized تصير بوحدة من الجلاندز. لا عادة الادينوما السنجل مثل ما شفنا بالادرينال كورتكس localized neoplastic proliferation neoplastic يعني mass. تمام؟ The primary, it is associated with it is related to parathyroid adenoma. There is increase in serum. High adenoma will secrete excess PTH in bouts, مو sustained in bouts. Serum calcium will be elevated. And the serum phosphate will be suppressed. This is related to هذه mechanisms, the physiological mechanisms اللي قلنا عليها. When there is excess PTH, there will be excess absorption of calcium from the GIT, increased secretion reabsorption from the GIT from the renal tubules, and excess dumping or loss or excretion of phosphate. فاش حيصير decrease serum calcium. laboratory finding شنو نشوف البي تي اتش عالي تمام. calcium is increased والserum phosphate is lower related to excess excretion of phosphate. تمام. Whereas in the secondary hyperparathyroidism, هذول السكندري hyperparathyroidism قلنا it is related to chronic renal failure. من يصير chronic renal failure شباب شو يصير؟ There is decreased ability of the renal tubular cells to dump or to excrete phosphate. فشي يصير الفوسفات عالي in the blood. Phosphate عالي in the blood because inability of the renal tubules to excrete this excess phosphate. من يصير excess phosphate ايش حيسوي؟ Yes, calcium it will bond to the active form ionized form. واحنا قلنا 60% is bonded to protein والرمنت هو bound with phosphate, يسوي complex ويا الفوسفات والباقي هو complex, it is the free type, it is the active form. فمن يزيد الفوسفات راح شنو؟ active form or the ionized calcium will be lower. This will stimulate the PTH secretion by the chief cells. تمام؟ من يصير decrease in the increase the PTH secretion ايش حيصير؟ chronic renal failure chronic hypocalcemia chronic hyperphosphatemia. تمام. There will be sustained stimulation of the four glands كلهم تمام. The four glands they become hyperplastic. So in secondary hyperparathyroidism or in chronic renal failure there is almost parathyroid hyperplasia. مو adenoma, parathyroid hyperplasia. All four or the four parathyroid glands are hyperplastic, secreting excess PTH. زين laboratory finding شو نشوف بي تي اتش بي عالي ولا لا؟ عالي تمام. whereas the calcium is low, the free type will phosphate is increased. Yes. Then increase in serum PTH secondary to chronic renal failure, inability of the renal tubular cells to excrete excess phosphate, and decrease GIT calcium absorption. ليش؟ إذا هو chronic failure ليش يأثر على GIT absorption of calcium؟
لأن يحفز الكوندكشن of vitamin D to
عافية. There is no converted vitamin. There is no more converted or active form of dihydroxy alpha 1 يعني dihydroxy form of vitamin D to increase the يعني absorption of calcium from the gut. Then, and also there is a chronic low level of serum calcium and hyperphosphatemia. Okay. ده tertiary type شباب. tertiary شنو معناها؟ فد واحد عنده يعني long standing chronic renal failure. long standing chronic renal failure. زين there is persistent PTH. يظل يصير عنده persistent PTH. هو متعود على high level of PTH أو عنده hyperplastic glands. There is sustained or chronic or persistent high PTH level. So even after correction of the secondary type, the patient also develop excess hyperparathyroidism or excess PTH secretion. يعني يصير عندهم the parathyroid gland is accommodated with chronic. In case of chronic renal failure, it is accommodated for elevated level of PTH secretion, parathyroid hormone secretion. So the patient have secondary elevated يعني يصير عندهم شلون الادينوما يعني because of sustained level of PTH even after correction of the secondary hyperparathyroidism. It is associated with elevated calcium. So the three histological pattern, the most common cause or etiological factor of primary hyperparathyroidism is adenoma in most common cases, in more than 80% of the cases. Or it can be related to hyperplasia, parathyroid hyperplasia, or rarely to parathyroid carcinoma. The risk factor, either there's a certain family history or an association with the multiple endocrine neoplasia type 1 and type 2A, or irradiation to the neck. The signs and symptoms of primary hyperparathyroidism is mainly related, can be asymptomatic, primary hyperparathyroidism. In a symptomatic form, it is related to, clinically apparent, related to metastatic, deposition of malignancy. Whereas the asymptomatic hypercalcemia is related to primary hyperparathyroidism, or it can be symptomatic, and the symptoms are mainly related to excess serum calcium. That is nephrolithiasis or nephrocalcinosis. Nephrolithiasis means there is stone formation in the kidney, whereas nephrocalcinosis, deposition of calcium or calcification in the renal tubules, nephrocalcinosis. The effect on bone resorption is increased, associated with the bone fibrosis, bone pain, and pathological fracture, or even cyst formation within the bone due to excess bone resorption. Osteitis fibrosa cystica, fibrosis with cyst formation. And resorption, increased bone resorption, or pathological fracture. Neuromuscular weakness and fatigue due to hypercalcemia, and also hypercalcemia have a CNS manifestation like depression and seizures, and cardiac manifestations including aortic calcification and mitral valve calcification. This is called metastatic calcification or disseminated calcification. Then this is renal tubules. There is calcification or calcium deposition within the renal tubules, within the lumen of the renal tubules. This is called nephrocalcinosis. Bone fibrosis or bone osteitis fibrosa cystica. This is bone. هاي شوفوها شباب. هاي شنو؟ هاي bone specule. هاي bone specule. تمام؟ هذا الاوستيوبلاست. زين. So these are streams. شوفوا هذا شوفوا هذا الستريمينج. هذا الستريمينج شباب. شوفوا هذا الفايبروسيس. This is bone fibrosis, increasing bone fibrosis. هذه bundles of fibrosis. This is the bone specule. Osteoblast are seen on as a ring, and the osteoclast, the bone resorbing cells, and these are bundles of fibrosis.
دكتورة هاي الدوائر شنو
وينها؟
هاي اللي حواليها
هذه شوفيها شكلها مالتي نيوكلييتد جاينت سيلز. هذه الاوستيوكلاست البون ريزوربينج سيلز. اي هاي البون سبيكيولز. هذه اكثرها الاوستيوكلاست. increased osteoclastic activity. مالتي نيوكلييتد عادة هي الاوستيوبلاست تكون. لا هذه الاوستيوبلاست bone forming cells. مو اكو تو تايب bone resorbing cells, the osteoclast and the bone forming cells. So increased bone fibrosis, osteitis fibrosa cystica, laying down of fibrous tissue, and cyst formation within the bone, especially periosteal cyst formation. This will increase the يعني واحدة من presenting يعني complication. ممكن يجي patient عنده pathological fracture وهو ما يعرف نفسه هو عنده يعني الأدينوما، فتكون عادة asymptomatic. زين. The adenoma مثل ما قلنا الأدينوما usually single almost always and mostly seen in the inferior glands. Is well encapsulated, soft, tan, red, small, and composed of chief cells and often contain foci of oxyphil cells with little or no fat. تذكروا النورمال هيستولوجي اللي شفناها بالبداية section مالت النورمال هيستولوجي قلنا islets of chief cells, occasional islets of oxyphil cells with lobules, intervening lobules of mature adipose tissue. حتى تفرقوها عن النيوبلازم. This is هذه شنو؟ هذه الفايبرس كبسول. This is the fibrous capsule. وهذا شنو باعوا شباب؟ شنو هذا؟ هذا الثايرويد. هي وين لاطشة على الثايرويد، parathyroid. مو تمام؟ هي أصلاً جيران الثايرويد. مو تمام؟ This is باعوها هذه thyroid follicles. قلنا احنا نشوف النورمال وبعدين نجي على النيوبلازم. And this is the neoplastic proliferation of chief cells. شوفوا there is no lobules of adipose tissue مثل ما شفتوا بالهيستولوجي بالبداية. تمام. This is the neoplasm للfollicular adenoma اللي شفناها بالثايرويد. These are mainly chief cell proliferation. ماكو oxyphil cells, chief cells. هذه شكلها تكون uniform. حلو شكلها uniform regular with يعني clear cytoplasm. Then parathyroid adenoma in a solitary, single, mainly in the inferior glands. Then this is the excision. The treatment here شنو؟ treatment شنو؟ surgical excision. Actually to correct the serum calcium. This is the normal one. This is the normal inferior parathyroid gland. وهاي هي النيوبلاستيك يعني كبرانة. هاي النيوبلاستيك. شوفوها شلون enlarged adenoma surrounded by capsule. تمام. And this is the normal small thyroid, parathyroid gland attached to the posterior surface of thyroid. The secondary type, secondary in Jabal secondary, it is related to chronic renal failure when there is inability of the renal tubules to excrete phosphate, and this will causing يعني secondary decrease in the level of ionized calcium. This is associated with vitamin D deficiency and osteomalacia secondary to inability. شنو؟ شكرا. The skeletal changes are osteitis fibrosis cystica, osteomalacia because of increased level of PTH and increased bone resorption, called renal osteodystrophy. What is renal osteodystrophy? It is skeletal manifestation of secondary hyperparathyroidism related to chronic renal failure. The morphology طبعا هي like نفس features مالت primary hyperparathyroidism bone changes and long-standing secondary hyperparathyroidism resulting in what we call it autonomous adenoma, or there is sustained excretion of PTH even with correction of the level of serum calcium. It is called tertiary hyperplasia. وهذه هي الجدول hyperparathyroidism primary و secondary will tertiary. Serum calcium is high in primary hyperparathyroidism. It is lower in primary hyperparathyroidism. The serum calcium is high, phosphate is lowered, and the PTH is high. This is in the primary. Whereas in the secondary form, sustained stimulation for PTH secretion. This is related to inability of the kidney to excrete serum phosphate, and this will lower or increase the combination of this phosphate with the active form and result in lowered serum calcium. Whereas in the tertiary type, there will be what we call it autonomous adenoma or sustained production of PTH. This will result in sustained PTH will result in high PTH, high level of serum calcium, even with the correction of serum level. Hypoparathyroidism شباب الهايبو دائما الهايبوباراثايرويدزم is related either to core excision, surgical excision يعني يشيلون الثايرويد gland يسوون ثايرويدكتومي ويا ما يشيلون ثايرويدكتومي شو يسوون؟ يشيلون الباراثايرويد and this will result in hypoparathyroidism or autoimmune damage to the parathyroid gland, autoimmune damage. This will result in lower serum PTH and lower serum calcium and decreased bone resorption. Also hyperphosphatemia due to absence of PTH to increase the renal reabsorption of phosphate, and the increased cell excitability due to due to hypocalcemia, cell excitability, numbness, tingling, tetany, and muscle spasm and paresthesia. These are related to any manifestations of low serum calcium, hypocalcemia. The life-threatening complications, including severe seizures and cardiac arrhythmias. Arrhythmia and atrial fibrillation are related to hypocalcemia. So it can be surgically induced, mainly, the most common cause is surgically induced after any removal or excision with thyroidectomy. يسوون parathyroidectomy also or congenital absence of all the gland or autoimmune destruction. نفس الكلام due to reduced serum ionized calcium, perioral tingling, paresthesia, titanian muscle cramps and convulsions, arrhythmias, cardiac arrhythmias, mental change, irritability and psychosis, and intracranial change including calcification of the basal ganglia and calcification of the lens. زين. شباب بقى عندنا توبيك اللي هو هذا هو multiple endocrine neoplasia. Multiple endocrine neoplasia. Endocrine system or multiple endocrine neoplasia. It is a syndrome. هذا topic واحد. It is a syndrome related to neoplasm or يعني adenoma or hyperplasia or carcinoma of more than one or يعني up to 3 endocrine glands. So it is disorder of various endocrine glands and it is divided into 2 syndromes, MEN 1 and MEN 1 and MEN 2. It is autosomal dominant and recessive in type 1 and it is characterized مثل ما قلنا hyperplasia, adenoma, benign neoplasm or carcinoma. Either hyperplasia or adenoma or carcinoma of multiple endocrine glands or organs. زين المين 1 شباب المين 1 it is the disease of 3 P's فضوها 3 P's parathyroid, pancreatic, pituitary. Parathyroid hyperplasia or multiple adenomas, عادة parathyroid hyperplasia اللي شفنا هسه parathyroid hyperplasia or adenomas. That will result in any secondary hypercalcemia, parathyroid hyperplasia, pancreatic tumors, that is insulinoma or gastrinoma, and this is the most common or it is the most serious form, result in hypoglycemia, which is fatal here, and the third one is pituitary tumor, most commonly prolactinoma. So 3 P's, خلوا بالكم parathyroid hyperplasia or adenoma present in up to 95% of the cases, result in hypercalcemia وهي hypercalcemia كل الفيتشرز هذه اللي of bone resorption and making it the most presenting symptom. And pancreatic tumor, benign tumor اللي هي most commonly gastrinoma. إذا gastrinoma شو تسوي complication؟ تسوي زولينجر أليسون syndrome. إذا insulinoma شو تسوي؟ hypoglycemia which is usually fatal or the most common cause of death, whereas in the pituitary it is associated with prolactinoma or prolactin secreting adenoma. So MEN 1 سهل 3 P's parathyroid, pancreatic and pituitary. And it is caused by germline mutation of MEN 1 tumor suppressor gene. Germline mutation. MEN 2 شباب it is divided into MEN 2A or MEN 2B أو يسموه MEN 2 3. زين MEN is divided into 2. It is both of them sharing medullary carcinoma of thyroid عادة medullary carcinoma of thyroid or pheochromocytoma medullary carcinoma of thyroid. زين medullary carcinoma of thyroid اللي قلنا عليها هي شنو؟ parafollicular cell carcinoma secreting excess calcitonin with foci of C cell hyperplasia. زين عادة medullary carcinoma is also associated. There is carcinoma of the in medullary type, which is of neuroendocrine origin, is associated also with foci of C cell hyperplasia in the non-neoplastic thyroid tissue. زين ماشي. Medullary carcinoma is associated with foci of C cell hyperplasia. C cell hyperplasia. زين مثل الجاسترينوما G cell hyperplasia. The second one is pheochromocytoma. Adrenal medullary tumor. تذكروا disease of 10 وقلنا عليه medullary adrenal medullary tumor in 50% of the cases, and parathyroid hyperplasia. Parathyroid hyperplasia, that is a primary hyperparathyroidism. So main two, the main component is medullary carcinoma of thyroid, pheochromocytoma, and parathyroid hyperplasia. Whereas main 2B like an extra endocrine manifestation. They share the medullary carcinoma of thyroid, parafollicular cell tumor, with pheochromocytoma, also seen, and there is an extra endocrine neoplasia or extra endocrine manifestation, including ganglioneuroma in the GIT or in the oral, the lips, ganglioneuroma, tumor of ganglion cells, or Marfanoid habit, long bone that resemble that of Marfan syndrome. زين فنفس الشيء medullary carcinoma والpheochromocytoma are shared with men 2A. بال 2A اكو primary hyperparathyroidism. هنا in men 2B there is an extra endocrine manifestation including ganglioneuroma and Marfan's habits. Okay, long bones. خلاص الآن ما عندي شيء بعد. عندكم سؤال شيء؟ autonomous adenoma. As autonomous adenoma, the patient accommodate, because he is a case of chronic renal failure, he is accommodate for sustained level, or there is chronic stimulation for the parathyroid gland to secrete PTH. حتى من يصير correction هذا sustained PTH production راح يبقى. Sometimes like autonomous adenoma, يعني يصير في شيء مثل النيوبلازم. الادينوما هي أو الهايبربليزيا is chronic because of this chronicity. There is يعني makes a response to يعني correction of serum calcium because of this sustained long-standing PTH secretion. So even with correction of serum calcium and phosphate, there is no return to normal. يعني هي بتبقى الادينوما secreting PTH. زين هذا يعني laboratory finding نشوف increased level of PTH, نشوف correction مع السيرم كالسيوم والفوسفيت. مو مثل السكندري لا يكون الفوسفيت عالي والسيرم كالسيوم lower. هناك لا يصير correction, يصير normal serum calcium والفوسفيت, but there is still a sustained production of serum calcium will be corrected, but there is sustained production of PTH. يبقى PTH عالي عند السيرم. إذا رجع للنورمال هذا secondary. إذا بقى عالي ويا الكوركشن هذا صار تيرشن. الاسيمتومات مش بيه. يعني هو صار عنده complication مع السكندري تايب يصير كوركشن مدام يعني السيمتومز مفروض تقل مدام صار كوركشن أو سيرم كالسيوم. هي مو adenoma, it is not adenoma, it is sustained stimulation of the chief cells, a failure of response to correction of serum calcium. يبقى عندنا فقط الاندوكراين بنكرياس ان شاء الله وننتهي.